Thank you very much to everybody to join us in this webinar. The topic of the webinar will be United Airway Disease. It's for me a great pleasure to introduce the speaker of the webinar is the Professor Angelica Tiotiu, a Romanian-French allergist and pulmonologist, currently in charge of the Department of Pulmonology at the University Hospital of Nancy, France. Professor Tiotiu is deeply involved in the scientific work of Interasthma in the context of INES network, Interasthma Scientific Network. And Professor Tiotiu is the first author of a manifesto on United Airway Disease, published on Journal of Asthma that is currently the official journal of Interasthma. More than 3,000 colleagues worldwide downloaded this document. I'm proud to introduce Professor Tiotiu, that she will present the content and the meaning of this manifesto on United Airway Disease. Thank you, Angelica.
Hello, thank you very much, Professors Braido and Goulet, for the invitation to give the talk today. I will start my presentation on the manifesto on United Airway Disease. Just a moment, please. I hope that everyone can see my slides. As you know, we published the Manifesto on United Airway Diseases, an Interasthma document the last year, and I will present the most important points of our view of Global Asthma Organization during this hour. Please find here my disclosures. In my plan, after a short introduction, I will define the manifesto, the concept of United Airway Disease. I will focus on chronic rhinitis and asthma and chronic rhinosinusitis and asthma before to conclude and to finish with take-home message. The manifesto is a declaration of the beliefs, opinions, motives, and intention of an issuer, be it an individual or a group. United Airway Disease is an ancient concept currently object of research and debate that allowed us, the Global Asthma Organization Association, to take a position in the light of available evidence. The aims of the manifesto is to promote new ideas with predictive notions and to provoke changes. In the context of healthcare, a manifesto describes achieved evidence, required actions, and needed investigations. The structure of the manifesto include 5 steps. We define, we know, we state, we advocate, and we propose based on the current available data. And in our manifesto, we talk about the chronic rhinosinusitis and the relationship with asthma, COPD, bronchiectasis, cystic fibrosis, and OSA, about the chronic rhinosinusitis and asthma, COPD, bronchiectasis, cystic fibrosis, and OSA, and nasal polyposis and the relationship with asthma, COPD, bronchiectasis, cystic fibrosis, and OSA. However, for today, I will focus just on the impact of chronic rhinosinusitis and chronic rhinitis on asthma, because the subject is too large. As you know, upper and lower airways present anatomical and functional similarity, including the cleaning, the conduction of the air to the periphery of lungs, and current data support the concept of United Airway Disease for the both phenotypes, allergic and non-allergic. You can see here the similarity in the structure of the nasal mucosa and bronchial mucosa, because we have the same epithelium with ciliated cells, the cells producing the mucin, the same basal membrane, conjunctive tissue with the same inflammatory cells. The only one difference is the presence of the smooth muscle in the airway, in the bronchial mucosa. We can see here also histological similarity. Firstly, nasal here we can see normal nasal mucosa, and in the right side, the nasal mucosa from a patient with nasal polyps with nasal remodeling and inflammatory cells. And similarly, we can see here then the bronchial mucosa from a healthy control, and in the right side, the bronchial mucosa from severe asthmatics with the same inflammatory cells, eosinophils, and bronchial remodeling. As you know, we can see the bidirectional nature and similar mechanism more evident in the allergic phenotypes, because the nasal provocation with allergen induces bronchial inflammation, and vice versa. Bronchial provocation with allergen induces nasal inflammation. Nasal mucosa and bronchial mucosa are exposed to the same irritant, to same infectious agents, and to same allergens. So the inflammatory cells and the inflammatory mechanism are very similar. But not only the inflammatory mechanism, but also the nasal and bronchial remodeling with activation of the epithelial mesenchymal transition unit in the both cases, inducing the remodeling of the bronchi and nasal mucosa, angioedema, and airway hypertrophy, airway smooth muscle hypertrophy. We define united airway disease as the clinical picture characterized by the coexistence of upper and lower airways involvement, driven or not by a common pathophysiological mechanism, leading to a greater burden on patients' health status and requiring an integrated diagnosis and therapeutic plan. We will focus firstly on the chronic rhinosinusitis and asthma. The chronic rhinosinusitis is defined as the presence of at least two symptoms: sneezing, itching, rhinorrhea, or nasal obstruction, at least 1 hour daily for at least 12 weeks per year. And you know that 4 types of chronic rhinosinusitis are described: an infectious type, an allergic type, a non-allergic, non-infectious type, and mixed rhinitis. For the infectious rhinitis or rhinosinusitis, the terms are synonymous. We can see here the diagnosis criteria: the presence of a purulent secretion, crusting, facial pain, or loss of smell. The diagnosis is confirmed by nasal endoscopy, and we need to do the microbiological analysis of nasal content and complete by a sinus imaging. For the allergic rhinitis, the symptoms are usually watery anterior rhinorrhea, sneezing, nasal obstruction, and itching. We need to have a positive skin prick test or serum-specific IgE to aeroallergens, and we can complete by nasal endoscopy. Non-allergic, non-infectious rhinitis, it's a very heterogeneous subtypes of chronic rhinitis, and includes occupational rhinitis, hormonal rhinitis, drug-induced rhinitis, gustatory rhinitis, senile rhinitis, and idiopathic rhinitis. The diagnosis need the medical history of nasal symptoms. Usually, we have negative skin prick test or serum-specific IgE for the air allergens. And if we can do an anterior rhinoscopy or nasal endoscopy, we can see no sign of infection. Mixed rhinitis is a type of chronic rhinitis that include both infectious and that include the criteria from both infectious and allergic rhinitis, at least 2 symptoms. We know that allergic rhinitis, the first and more important phenotype associated with asthma, that 80% of asthmatics have allergic rhinitis, and conversely, 30% of patients with allergic rhinitis have asthma. The allergic rhinitis is a risk factor for asthma with a odds ratio superior to 3. And the phenotype is associated with early onset allergic asthma. The presence of allergic rhinitis is associated with poorer asthma control and directly proportional with the severity of allergic rhinitis, with frequent exacerbation and emergency visits, low quality of life, high healthcare cost, and has not significant effect on the progression of asthma severity. We know that allergic rhinitis is also an early life predictor for an accelerated decline in lung function with a odds ratio superior to 2 and frequently associated with airway hyperreactivity or airway obstruction, even in the absence of asthma symptoms. And you can see here that the association of allergic rhinitis and asthma is in the large cohort was studied at 20 years old. We can see a significant difference in bronchial hyperresponsiveness quotient for the group who have asthma plus rhinitis versus the patients with asthma only or rhinitis only, of course, versus healthy volunteers. Allergic rhinitis is also associated with increased levels of nasal oxide nitrate and correlated with nasal symptoms and exhale fraction of oxide nitrates. It also associated with increased levels of FeNO, and the increased levels of FeNO is associated with a longer allergic rhinitis duration, impaired lung function, more severe symptoms, and more frequent airway hyperreactivity. 1/4 of the allergic rhinitis patients with FeNO superior to 50 ppb developed asthma at 2 years follow-up. The electronic nose could discriminate subjects with allergic rhinitis from those with allergic rhinitis and asthma. We know also that the sensitization to house dust mites, pet dander, pollen, fungi, and cockroaches is associated with allergic rhinitis and asthma development, but also with symptoms exacerbations. And you can see here in this study that the patients with allergic rhinitis to pollens have an increased risk to develop asthma at 8-year follow-up, near 8. Similarly, for the patient with allergic rhinitis who are sensitized to pets with risk at 18, and for the house dust mites, more elevated with risk at 38. Conversely, the reduction of allergen exposure is associated with a reduction of symptoms in patients with house dust mite-driven allergic rhinitis and asthma. Unfortunately, the preventive measures of allergen exposure alone is not sufficient. So you need some therapeutic measures. We can treat allergic rhinitis by specific allergen immunotherapy, nasal corticosteroids, and antihistamines. The specific allergen immunotherapy showed benefits by improving nasal and asthma symptoms, medication use, asthma exacerbations, and airway hyperreactivity, decreases the risk of asthma onset, allergic disease progression, or development of new sensitization, and increase the quality of life of patients. You can see here in this meta-analysis several studies that compare the effectiveness of subcutaneous and sublingual allergen immunotherapy that showed benefits in allergic rhinitis, but also increasing data showed the benefits in asthma, even the significance of these results are lower. Topical corticosteroids are the most effective treatment of allergic rhinitis and asthma. And you can see here in this study involving more than 2,000 patients treated by intranasal corticosteroids, inhaled corticosteroids, or intranasal and inhaled corticosteroids, all the patients having allergic rhinitis and asthma. The treatment by intranasal corticosteroids and the association inhaled and intranasal corticosteroids significantly improved the nasal congestion, and also the rhinorrhea in the same groups, and the sneezing. In the same time, we can see here a significant improvement of the airway hyperreactivity in the patient receiving intranasal corticosteroids and inhaled corticosteroids versus control, or the patient receiving just intranasal corticosteroids. The antihistamines is the cornerstone of the treatment of allergic rhinitis. Of course, as you know, in practice, we need to use more the new generation antihistamines with less sedative effects. And we can see here epinastine, olopatadine, cetirizine, or levocetirizine, and the most recently bilastine and fexofenadine. In this large meta-analysis, we can see the effect of antihistamines in the patients with allergic rhinitis and comorbid asthma. Of course, all the symptoms of allergic rhinitis are improved by the antihistamine treatment, but also we can see benefit on asthma symptoms by the reduction of cough, wheeze, difficulty of breathing, and chest tightness, but also an improvement in the FEV1 and PF, and sometimes a decrease of the rescue bronchodilator use. The association nasal antihistamine and corticosteroids has a potent local effect with a fast action and minimal systemic side effects. And you can see here in this recent study that the association azelastine fluticasone administered intranasal in a large cohort with patients with allergic rhinitis, several of them with asthma, a significant improvement of nasal symptoms during the study for 2 weeks, but also of asthma symptoms. Just to summarize our acknowledges about the treatment of allergic rhinitis and the impact on asthma, allergen-specific immunotherapy have a positive impact on asthma with the decrease of the risk of asthma onset, improvement of symptoms, decrease of exacerbation rate, reduction in medication use, decrease of airway hyperreactivity, and improvement of quality of life. For the nasal corticosteroids, we can see an improvement of symptoms, reduction of the severity, decrease of the rescue medication use, decrease of airway hyperreactivity, and an improvement of lung function. For the antihistamines, we can see a delayed asthma development, an improvement of symptoms and of related quality of life. And for the association intranasal corticosteroids and the local antihistamines, a decrease of asthma symptoms and a reduction in reliever medication use. Conversely, leukotriene receptor antagonist, an anti-asthmatic treatment, is effective to treat allergic rhinitis. And you can see here in this recent meta-analysis included all the published study on the effects of leukotriene receptor antagonist on the allergic rhinitis, that there are important significant benefits on the daytime symptoms score of rhinitis, of the asthma, for the nighttime symptom score of asthma at 2 weeks of treatment, but also an improvement of the composite nasal symptom score at 2 weeks of treatment. We have also now several biological therapies developed for severe asthma treatment that show the efficacy in improving concomitant allergic rhinitis. And in this study published 2008 in a cohort including more than 4,000 patients receiving an anti-IgE antibody for 28 weeks, a significant improvement, of course, on asthma score, but also on the nasal symptom score in patients with allergic rhinitis and asthma. In addition, both asthma quality of life and rhinitis-related quality of life were significantly improved. More recently, another study showed the benefits of the anti-IL-4 receptor antibody delivered for patients with asthma. 814 patients included with asthma and allergic rhinitis, receiving the treatment for 52 weeks. And we can see here a significant improvement for the week 12 of a rhinitis quality of life score in the patient receiving the treatment anti-IL-4 receptor antibody compared to placebo, and also the nasal symptoms were improved in the same time. Of course, as expected, the number of exacerbations of asthma were significantly reduced. We can see here also a significant improvement of the FEV1 and an improvement of asthma control. We can now summarize about allergic rhinitis and asthma treatment. Both allergic rhinitis and asthma could be treated by allergen immunotherapy, and need topical corticosteroids. However, several treatments, such as antihistamine delivered for allergic rhinitis, showed benefits on asthma, and conversely, several treatments delivered for asthma, such as biotherapy and leukotriene receptor antagonists, showed benefits on allergic rhinitis. We know that digital solutions to care and to manage allergic rhinitis and asthma are available to promote evidence-based information and to enable patients to provide their doctors with feedback and data on their health. So we need to use in our practice this solution. What you know about the non-allergic rhinitis and asthma? Non-allergic rhinitis has a prevalence at 10% in a population with 15 years old years, and the presence of non-allergic rhinitis is a risk factor for asthma. We will talk about two forms of non-allergic rhinitis associated with asthma, because for the other types, we don't have sufficient evidence. The occupational rhinitis is 3 times more frequent than occupational asthma, and the risk factor for the development of occupational asthma. Usually, the occupational rhinitis preceded occupational asthma and is frequently associated with occupational asthma for high molecular weight agents, with an odds ratio near 5. Usually, the moderate or severe occupational rhinitis is a predictor for nocturnal respiratory symptoms and associated with moderate or severe occupational asthma. Another subtype is the rhinitis in pregnant women with asthma. And we know that the presence of the rhinitis in pregnant women with asthma is associated with poor asthma control, sinonasal and asthma-related quality of life, increased anxiety symptoms, decreased lung function, and increased FeNO compared to those with non-allergic rhinitis alone. In addition, more than half of patients have moderate or severe rhinitis. But fortunately, we can see an improvement of symptoms during gestation with adequate treatment for asthma and rhinitis and monthly monitoring. Here, just to summarize the non-allergic rhinitis management, for the occupational rhinitis, the avoidance of the causal agent is mandatory. The patient need to use personal protection equipment, intranasal corticosteroids, and nasal saline irrigation. For the hormonal rhinitis, in practice, the patient need to do nasal saline irrigation. We state, rhinitis is a risk factor for asthma onset and makes its control more difficult. A combined management approach of chronic rhinitis and asthma is always needed. The management of allergic rhinitis and asthma is based on allergic avoidance and environmental control measure, allergen immunotherapy, pharmacologic or biological treatments. Digital solutions are useful for the management of chronic rhinitis and asthma. We advocate the development of exhaled biomarkers able to discriminate rhinitis or asthma from the association asthma and rhinitis. Study to assess the overall efficacy of different treatments from the patient point of view on united airway disease. Better education of medical students, physicians, and patients on chronic rhinitis and asthma. We propose the implementation of evidence-based guidelines care in each country to ensure to all patients with chronic rhinitis and asthma the access to the right diagnosis and treatment. The screening for asthma for all patients who have chronic rhinitis. Specialized care for the patients with suboptimal disease control despite optimized care. Now we will talk about chronic rhinosinusitis with or without nasal polyps and asthma. As I already told, the chronic rhinosinusitis is synonymous to infectious chronic rhinitis. Chronic rhinosinusitis is frequent in patients with asthma. We know that asthma increases the risk for developing chronic rhinosinusitis, and vice versa, chronic rhinosinusitis is associated with an increased risk for developing asthma, a risk that is higher in young men between 20 and 39 years old. Chronic rhinosinusitis is frequently associated with more severe asthma, uncontrolled disease, more frequent and severe exacerbations, greater airway remodeling, and worse quality of life. Conversely, asthma is associated with increase of frequency of chronic rhinosinusitis exacerbations, a higher SNOT score, a lower response to local corticosteroids, a prolonged systemic therapy by using more frequently oral corticosteroids or biologics after surgery, with increase of chance of recurrence of chronic rhinosinusitis after surgery and increased risk of perioperative complication. We know that we need to know that a potential role of the infectious agents such as Staphylococcus aureus has been also evoked. For the chronic rhinosinusitis, we have several therapeutic options, such as nasal corticosteroids, nasal saline irrigation, oral topical antibiotics, and surgery. We can see, we know that nasal corticosteroids is the most important treatment of chronic rhinosinusitis, but the appropriate local delivery is crucial. And you can see here in this large study, patients with chronic rhinosinusitis, adult patients, treated by mometasone versus placebo for 24 weeks. All patients have chronic rhinosinusitis and asthma. And you can see a positive impact of the nasal sinus score, of course, but also on asthma symptoms. However, there are no significant impact on the lung function and on the related quality of life. Long-term low-dose treatment by macrolides show benefits in patients with asthma and chronic rhinosinusitis related to humoral immunodeficiency. We can see here in this small study, including 39 patients with chronic rhinosinusitis and severe asthma, treated by macrolides or immunoglobulin supplementation for the humoral immunodeficiency for 1 year. You can see here that at the baseline, the number of exacerbations was very high, 6 per year, and needed treatment by oral corticosteroids and antibiotics. And after 1 year of treatment, the exacerbation rate was lower at 1.79 for the exacerbation severe of asthma and sinusitis, but also the antibiotic consumption was lower. In the same time, we can see here a significant improvement of the lung function in this patient. Nasal polyps is usually associated with asthma, and you can see up to 35% of patients with nasal polyps developed adult onset asthma. Usually, the nasal polyps preceded asthma. And conversely, if we prescribe a sinus CT scan in severe asthma patients, we can see and we can find nasal polyps in near half of cases. And you can see here in this CT scan a typical image of nasal polyposis. Nasal polyposis contributes to asthma severity, exacerbations, decline of lung function, and is associated with higher oral corticosteroids use. However, we have now evidence that the biological therapies developed for severe asthma that showed effectiveness on nasal polyps also. We can see here a study including patients with severe allergic asthma and nasal polyposis receiving treatment by an anti-IgE antibody for 6 months. And we can see a significant improvement of all nasal symptoms, pruritus, loss of smell, rhinorrhea, sneezing, nasal obstruction, with a significant decrease of the number of acute rhinosinusitis from 4 before the treatment to 1 after treatment, with a significant improvement also of the sinus imaging. Of course, as expected, all the respiratory parameters were improved. This dyspnea, the cough, we can see a reduction of daytime and nocturnal asthma symptoms per week, a decrease of the number of salbutamol rescue per week, an improvement of asthma control score, a decrease of the number of asthma exacerbation also, and an improvement of lung function. In addition, the blood eosinophil count was significant decreased after 6 months of treatment by an anti-IgE antibody in this population. Similar effects were found also for another biological therapy, the anti-IL-4 receptor antibody. And we can see here in this large cohort, including 724 patients with nasal polyps, with associated asthma for 428 of them, receiving therapy by anti-IL-4 receptor antibody or placebo. And we can see a significant improvement of nasal polyp score in all patients versus placebo, without significant differences between the patients with asthma and without asthma, and an improvement of the sinus imaging, an improvement also of SNOT-22 score and of nasal score at 24 weeks of treatment. Of course, as expected, the lung function was significantly improved also at 16 weeks of treatment, with a persistent effect to 24 weeks of treatment. Similarly, the asthma control questionnaire score was significantly improved at 16 weeks of treatment, and the effect was persistent until 24 weeks of treatment. Similar results were found also for the anti-IL-5 antibody in the subgroup of the study MENSA, including 80 patients with nasal polyps and severe eosinophilic asthma receiving the treatment for the 24 weeks. And we can see here a significant improvement of the SNOT-22 score at 24 weeks of treatment, more evident for the groups with nasal polyps associated to asthma. In the same time, with an improvement of the St. George Respiratory Questionnaire score. Similarly, for the anti-IL-5 receptor antibody, in the subgroup of the study ANDI, including 96 patients with nasal polyps and severe eosinophilic asthma receiving the treatment for 24 weeks, we can see here a significant improvement of the St. George Respiratory Questionnaire, but also a significant decrease of the SNOT-22 score at 24 weeks of treatment, but also at already present at 4 weeks of treatment. In patients with allergic exacerbated respiratory disease, the aspirin desensitization improved disease outcomes. And we can see here in this recent meta-analysis, including all the published study of patients with aspirin exacerbated respiratory disease receiving high doses of aspirin for at least 6 months. We can see here the improvement of sinus symptoms score, of SNOT-22 score, but also an improvement of the lung function, asthma control, a decrease of the number of hospitalization for asthma exacerbations, and also a reduction of the rescue medication use. If the pharmacological treatment is insufficient, the surgical management is necessary for chronic rhinosinusitis. Endoscopic nasal surgery could improve asthma control and quality of life, decrease asthma attacks and hospitalization, and decrease asthma rescue medication needs, as also the oral corticosteroids use. And we can see here in this meta-analysis that the endoscopic sinus surgery showed important benefits on the patients having chronic rhinosinusitis and asthma by improving all asthma parameters. The mixed chronic rhinosinusitis and asthma and the less form of the chronic rhinitis. We know that in the definition of mixed chronic rhinosinusitis, we need at least 2 characteristics from the other groups: allergic chronic rhinitis and infectious rhinitis. So most of patients have a purulent secretion, but also an allergic background. The most recognized and the most frequent agent, pathogen agent, is the Aspergillus fumigatus that could induce an allergen fungal rhinosinusitis in the same time with an allergic bronchopulmonary aspergillosis. We know that 80% of patients with allergic bronchopulmonary aspergillosis have allergic fungal rhinosinusitis. For the diagnosis, we have clinical criteria associated with radiological criteria and immunological criteria, such as a total serum IgE level superior to 1,000 units by milliliter, specific IgE for Aspergillus fumigatus superior to 0.35 Cu per liter, and the presence of the eosinophilic mucin in sinus. That is mandatory for the diagnosis of allergic fungal rhinosinusitis. Currently, we can treat the association allergic fungal rhinosinusitis with allergic bronchopulmonary aspergillosis with oral corticosteroids plus with or without antifungal agents for the exacerbation, and surgery with nasal corticosteroids and nasal saline irrigation for allergic fungal rhinosinusitis, and inhaled corticosteroids for allergic bronchopulmonary aspergillosis. Several publications showed benefits of the biologics developed for the severe asthma on allergic bronchopulmonary aspergillosis. So maybe in the future we will treat this patient with biologics therapies. We state chronic rhinosinusitis is frequent in patients with asthma and associated with a more severe disease, high number of exacerbation, and increased oral corticosteroids use. Concomitant asthma is associated with more severe chronic rhinosinusitis. Medical and or surgical treatment of chronic rhinosinusitis improves asthma outcomes. Biological therapies for asthma and aspirin desensitization for patients with aspirin exacerbation respiratory disease improve the course of both chronic rhinosinusitis and asthma. We advocate systematic assessment of chronic rhinosinusitis in all patients with asthma and ONT symptoms and vice versa. Optimized treatment of patients with asthma and chronic rhinosinusitis by specialized care in a multidisciplinary center. Future research to compare the efficacy of various biological therapies between them and with the surgical treatment in patients with nasal polyps and asthma. We propose a systematic nasal examination by CT imaging and endoscopy in patients with asthma and suspicion of chronic rhinosinusitis. The screening for asthma in all the patients with chronic rhinosinusitis and respiratory symptoms, and the development of multidisciplinary teams, including ONT specialized and pulmonologists, in order to apply the personalized medicine to patients with chronic rhinosinusitis and asthma. In conclusion, chronic rhinosinusitis and asthma are often associated and share similar mechanisms in their pathogenesis. Treating both according to the concept of united airway disease and limiting the medication use represent interesting options in the era of the personalized medicine. More evidence exists for allergic rhinitis and chronic sinusitis with nasal polyps associated with asthma than for the other groups of chronic sinusitis. Future research is needed for chronic infectious rhinitis, mixed rhinitis, and non-allergic rhinitis associated with asthma in order to better understand the mechanism involved and to identify effective therapeutic options for the united airway disease. To take home a message, the management of united airway disease should be improved by using a multidisciplinary approach and the effective therapies targeting both upper and lower airway inflammation. Thank you very much for your attention.
Thank you very much, Professor Tiotiu, for providing us this really extensive overview of an interesting topic. Thanks to ARIA guidelines, we have focused our attention in the last decades on allergic rhinitis. But nowadays, you have shown us that we need a broader approach on united airways disease and pathology of the lower airways. Thank you very much for this. I have received some intervention, some questions from the audience. First of all, one colleague stated that one of the slogan of ARIA guidelines was, every time we are facing with asthma, we have to look at rhinitis, and vice versa. Every time we are looking at allergic rhinitis patient, we have to consider asthma. Now we have to modify this approach because besides allergic rhinitis, we have other kind of rhinitis. We have the rhinosinusitis, we have polyposis, we have the involvement of other pathologies such as sleep apnea and so on. The colleagues require us, so which is the first examination that we have to consider in facing a patient with united airways and asthma? Rhinoscopy?
Firstly, we need to do the prick test to allergen, in my opinion. And secondly, a rhinoscopy for the allergic rhinitis, yes.
Thank you very much, Angelica. Also because at least 50% of the patients are suffering from an allergic disease, but obviously we have to consider also the other part of this coin, in other words, the non-allergic patient. Another colleagues require some more information about this topic. In the past year, we considered the main treatment for upper airways antihistamine, non-sedative antihistamine, for example, bilastine and so on, and inhaled steroids. As you have mentioned, starting from asthma, but looking at the upper airways now, we have a significant number of biologics. Do you believe that this will be the way? In other words, the personalization of treatment also in high prevalence disease such as rhinitis or rhinosinusitis, or in the next year we will consider biologics only in patients with really severe disease of some subphenotypes, for example, patients with asthma and polyposis?
I think that the severe asthma patient with an allergic background, without nasal polyposis, who are treated by anti-IL-4 receptor antibody or anti-IgE antibody, they will not have needed to treat also allergic rhinitis, because the symptoms will be improved by this therapy. Conversely, for the patient with severe asthma and nasal polyposis without allergic background, the biological therapy are the first choice, in my opinion. But the anti-IL-4, anti-IL-5, and anti-IL-5 receptor antibody are not could not improve the allergic background, so could be a choice for the patient without an allergic background.
You have partially answered to another question that I have received from the user. In your daily practice, which biologic is or are your first choice or choices in the treatment of severe chronic rhinosinusitis with nasal polyposis refractory to usual treatment in a patient with severe asthma?
I don't have really a first choice. I do like my colleagues. Firstly, for a patient with severe asthma, severe eosinophilic asthma, and nasal polyps without allergic background, I will prescribe probably an anti-IL-5 antibody or anti-IL-5 receptor antibody, but this treatment is not approved for nasal polyps. It is just approved for the severe asthma, severe eosinophilic asthma, of course, the last one, because the anti-IL-5 antibody we can prescribe in patients with nasal polyposis and severe asthma, but the anti-IL-5 receptor antibody is efficient also on the nasal polyps, and increases evidence suggests this fact. For a patient who have severe allergic asthma and chronic rhinosinusitis, a mixed profile, allergic and nasal polyps, in my opinion, we need to try an anti-IgE or anti-IL-4 receptor antibody as first choice.
Thank you very much, Angelica. This is an open discussion also because every month is published a new trial providing us new ideas and new evidence. Obviously, we have to tailor the treatment according with the feature of the patient, but it's not so easy to define a first choice.
We don't have, currently, we don't have a perfect strategy to treat this patient. It was just my personal opinion.
It is in the aim and the mandate of Global Asthma Association to achieve the belief and the behavior and the idea and the knowledge that the physician worldwide have about the topic. This will be a topic that we will cover with a new investigation and new survey. We are at the end of our webinar. I would like to thank you, Angelica, again for your involvement in Global Asthma Association. And I would like to thank all the people attending this meeting. And I would like to encourage you to be part of a Global Asthma Association, to be part of the INES network, to join us and to attend the future webinar that will be developed and planned in the first and second semester of 2022. Thank you very much to all of you. See you next time.
Thank you very much for the invitation. See you.